All right, thank you so much for staying with Daybreak. Let's set the stage for this conversation we're about to have with Dr. Elizabeth Wala. She's the Program Director, Health Systems Strengthening at AMREF Health Africa. So now, right now as we speak, the Ministry of Health is warning that stigmatization of COVID-19 patients, and especially those who have recovered, could be detrimental to those affected and a hindrance to the fight against COVID-19. So the warning is coming on a day when 497 cases were reported, a majority of them being in Nairobi County, with the trend seemingly appearing to pick up as days go by. The ministry is telling Kenyans to adhere to all the measures put in place by the government to help contain the disease, as Raquel Muigai reports.
Since the first COVID-19 case was reported in the country in March, Nairobi County has been steadily recording an increasing number of cases at an alarming rate. As of Monday, Nairobi was leading with 5,705 cases, Mombasa following with 1,739, Busia with only 550, and Kiambu with 520.
In the last 3 days alone, Nairobi has registered 518 cases, and this indeed is a worrying trend, and something must be done. It is important that the residents of Nairobi are alert and are able to act very quickly in terms of adhering to the containment measures.
The scenario quite evident in today's briefing, where Nairobi registered 292 cases, Kiambu 62, Kajiado 51, Machakos 30, Mombasa 28, Busia 10, Uasin Gishu 8, Nakuru 5, Makueni 3, Narok, Nyeri and Meru counties recording 2 cases each, with Kakamega, Kericho, Kilifi, Laikipia and Nandi recording only a case each.
Getting this disease is not a crime, and those who are infected with this disease are not criminals. Profiling them and elevating, stigma in the society. Again, this is something that does not add value to this fight of COVID-19 and ends up stigmatizing the situation and making it even harder for us to be able to maintain our containment measures, for us to be able to work together, adopting a whole of society approach in dealing with this disease.
But of utmost concern is the systemic COVID-19 infection. New evidence indicates that COVID-19 does not only affect the respiratory system, but also other body organs, this proving a challenge especially to those who are placed under intensive care.
You find that these patients end up with multiple organ problems leading to what we call multiple organ failure. So when the lungs begin to fail, in sympathy the kidneys also slow down, the heart slows down. Notwithstanding the clotting problems that these people have, the cytokine storm, where your body in trying to fight the infection overdoes it and therefore puts the rest of the organs at risk.
While the ministry cites recoveries of patients admitted in the ICU are possible, there exists a set of challenges which pose a greater risk to those who are under ventilation.
That being an invasive procedure puts you at risk of getting secondary bacterial infection in the respiratory tract, which of course complicates your management.
Only 190 COVID-19 patients have ever been admitted in the intensive care unit since the virus marked its presence in the country, out of which 90 recovered, while another 73 succumbed. As it stands, only 36 patients are still admitted at various ICUs in different hospitals in the country. Raquel Muigai, Citizen TV.
So let's delve deeper into this conversation with Dr. Elizabeth Wala. She's the Program Director, Health Systems Strengthening at AMREF Health Africa. Dr. Wala, thank you so much for making time for us. So in your own assessment of how we've dealt with the virus...
Welcome.
Thank you so much. What do you make of how we've dealt with the virus this far? We see the numbers continue to surge. Now we're at 497 per day. Have we done a good job from your perspective?
Thank you, Trevor, for that question. I don't know whether we have a scale of good, better, best for COVID-19. What we know is that within our resources, in terms of our health systems, we need to be very careful, because if we misstep, then we are prone to get into a full-blown pandemic within the country. So we are seeing a rising number of cases, and of importance is that we are seeing quite a number of young people whom we thought would have a better immunity getting this disease. So with the containment measures lifted, especially for movement, it is upon us now to have this sense of responsibility, where without being policed. We are able to take precautions in how we handle ourselves so that we protect not only ourselves, but those around us.
Should we even have lifted the cessation of movement? Did we do that too soon?
I think it was a delicate balance between the economic effect of sustaining the containment measures vis-a-vis the health effects. And for many countries, it's almost like a watch and wait situation. So you can't predict how it will go with Kenya. In terms of livelihoods, health for us is not determined only by diseases, but also other social determinants. For example, if people are not able to earn a living, then we find the vulnerable in the population suffering, our children, our pregnant women, our elderly population, so leading to other outcomes of poor health, and thus becomes a cycle because then they are vulnerable to more infections. We also see that we have a lot of mental health issues coming up with being locked down. It's not easy to tell people to stay in one place. They need psychological, they need interaction with other people. They need to go out and make a living. So then there are also various mental health issues. But on the health systems issues, we have to keep on monitoring the trends that we are seeing. On my end, I wish the government will give us more than just figures or statistics, because we need to analyze the kind of infections we're seeing, apart from just talking about the location and the gender. Are we seeing more of people who are previously not having any underlying conditions getting infections? We need to also look at our hospitals' capacity. So initially, even people who had COVID-19 but didn't have symptoms were being admitted in the hospitals, and now we've seen our hospitals at least are overwhelmed by the numbers. So we have now shifted towards home-based care guidelines, where if you don't have any symptoms and you don't have maybe people at risk within the home environment, you're able to stay and isolate yourself responsibly and be followed up maybe daily. And if you have any symptoms, report this to the 719 line.
So you are the program director, Health System Strengthening, and what weaknesses have you seen in our health system?
Trevor, to be honest, our health system was not in a good shape even way before COVID-19. Our biggest issue for us is the number of healthcare workers, their training levels, their motivation, and that's at this point that I'd like to send my personal condolences to the family of the late Dr. Adisa Lugaliki, who was a personal friend and who lost her life from COVID-19. So we are seeing a number of health workers contracting the disease in the line of duty, and therefore stretching the already limited resources for human resources in terms of fighting this disease. We are also seeing that, of course, our infrastructure as in terms of the hospitals or the care levels for managing this disease are super stretched because other diseases haven't taken a pause, Trevor. We had the government talking about every county having at least 300 isolation beds, and that seems to be a dream in terms of whether or not we'll be able to achieve this. We are having issues with even our critical care space, leave alone just isolation units within the facility. And critical care space here looks at our ICU capacity, our ventilators, our oxygen supply, the people who work in these spaces, because we can't train health workers in critical care within 3 months. So we have to be very careful alongside that. Then we look at the resources set aside for managing the pandemic. Already the health sector receives quite a low, the budget that's allocated to the health sector is very low. And we have seen an improvement in terms of Treasury setting aside specific funding for this. We are yet to see some of this funding going towards what they're supposed to do, like recruitment of more health workers. I think there was 1 point something billion. We are yet to see these health workers recruited. We are seeing people personally raising funds through the COVID-19 fund. Private sector is leading this way. And we hope to see that this money is used efficiently, and there's accountability towards it. In line with purchasing of things like personal protective equipment for health workers and those interacting with this. We also have an issue in terms of our data management systems. So ideally, we should all be interconnected. My data in Nairobi should be available in Mombasa. So if I were to travel there and unfortunately get sick, at the touch of a button, you should be able to draw up all the information that you need to know about me. This data on my end should also be transmitted to the relevant authorities that need to have this collected. So our data information systems, which help us in decision making and which helps us in knowing how our trends progressing, needs to be upped so that we are not waiting for 24 hours, 48 hours to find out that someone had COVID and has traveled, interacted with quite a number of people, and we're not able to trace. And there are any other also weaknesses in the health systems. I would say the COVID-19 pandemic has been a blessing in disguise for us who work in this space, because what we are now seeing the government putting in place, county governments coming together, private sector talking, are things that we've been advocating for previously, so that we are able to strengthen this health system. So we hope that we learn from this, how we manage this pandemic, so that at the end of it, we have a health system that's able to not only manage COVID-19, but manage many other basic infections.
From where you stand, what is your assessment of our data collection? Because you've just talked about synchronizing our data so that information in Nairobi can be gotten in Mombasa and vice versa. We are now doing mass testing. Should we have gone with the random sampling, for example, which is more scientific, so that we know the actual number of Kenyans who have COVID-19?
Yeah, so when it comes to data, ideally, we should, I had really wished we had gone ahead with the Huduma number that had started, because this unique identifier is able to pull out your personal information, whether it's socioeconomic information, whether it is health data, because with one repository of knowing who Amakove Wala is, anyone, anywhere, with authority, of course, my authority, is able to quickly pull it out, as I'd mentioned, and make a decision in line with what is best for me in terms of management. So right now, what there is that if I go to one facility, even here within Nairobi County, and this is what is really hampering our efforts to manage this disease, is that unless the patient opens up, and unless they also know what they have been using, what conditions they suffer from, it's very hard. And that delays management of the patient, delays contact tracing, which is very important for pandemic response. It also delays any measure that may be taken in place to handle the situation. So we are seeing a number of people being admitted, and within the course of their management, then we find out that they were actually having one or two other diseases that they didn't mention or they were not aware of. When it comes to testing, unfortunately, our capacity for testing is quite stretched. And I know right now the government is focusing on symptomatic individuals who need to go to selected laboratory facilities to do the testing. If we had gone the way of community testing, the most ideal and cost-effective test for antibody test, because the antibody test uses blood to pick out infection, a history of infection, because if one gets the virus, then the body mounts a response and produces antibodies. Now, the current testing that you're using is called polymerase chain reaction test, a PCR test, that uses the live virus or the presence of particles or parts of the virus within the body. And that is more expensive. It takes a longer period of time, and even the collection of the specimen involves quite a lot of logistics. So to the best of my knowledge, the simple antibody tests are yet to be approved, even as WHO, are limited to using the DNA bits, which poses a risk for us. Yeah.
So now the government is pushing for more personal responsibility. Is this a fair position, considering that there's a difference between citizen responsibility and we are also now seeing stigmatization? Citizen responsibility would have meant that if I feel some type of way, I would come out and say it and readily give my official number. But now we are seeing stigmatization also coming in at the same time, very quick behind that footprint. So how do we balance these two, citizen responsibility and stigmatization?
Yes, Trevor, I would say our initial approach to the pandemic was wrong. We started on the wrong footing by basically condemning people who might be having symptoms. We issued threats. We arrested guys who were breaking down the containment measures. We quarantined quite a number of people coming in from the country who ideally, if the communication was done in a better way, would have been responsible enough to do this in their own settings. And so when a disease is pegged on behavior change for control, then we needed to have been much, much more careful and much more sensitive to the information that we gave out about the disease, to the laws that we put in place to manage the disease, to the enforcement of the same. Because you're telling me now, I need to wear a mask while in public. This information needed to have been broken down to why do I need to wear this mask? Where can I access this mask? And also why should I do it? And not saying that if you don't do it, I'm gonna take you up and the police is coming to beat you. Some people have died from being shot because they were not wearing a mask. And so this sends fear to the population. And many of the times the containment measures that are put in place are because we don't want to be jailed. They're not because we understand that this is a way in which we are able to manage our numbers. And so the public health response for it, unfortunately, went into the stigma side. We saw the initial barriers, how they were conducted, and the trauma that came from it. And so when now someone suspects or has symptoms, they actually think twice about going to seek care because they feel this is a condemnation, and if unfortunately they pass away, they'll be managed in ways in which we're not respecting our cultural and traditional ways. So it's good that there's now a push towards having conversations rather than threats, and I think we need to tone down the way we put across our messages. We need to involve more anthropologists. There's a reason why people study human behavior. We need to have a collective responsibility of supporting those who are not able to let's say, afford personal protective equipment like the masks, the face mask, or even the hygiene issues. Yeah. So that I'm in an environment that I understand why I should take certain measures, and I do it because I'm from that point of understanding and not because there is a legal threat hanging over my head.
So how do we do this now, Dr. Wala? Because it's a very interesting point that you bring, because this is a disease that can only be fought through behavior change as well. So it's incorporating two aspects. There's a friend of mine who's also infected, and she told me that this coronavirus and the COVID-19 is the most lonely disease she's ever gone through. So how do we change the mindset of the people now? Because we are looking for both behavior change and also trying to fight a virus at the same time.
Mm-hmm. Yes, so we are at that point where we're now encouraging home-based isolation for those who do not have any risk to their health or the people around them. We are making it, people are now coming out to say, I have COVID-19. And I think this helps break down the stigma, because in COVID-19, unfortunately, in the beginning, did not have a face. It's not like Ebola, where you'd have people having blood spewing out from many of the orifices of the body. So with COVID-19, it's symptoms of the respiratory system, so the coughing, the flu, the fever, which are more or less not very outwardly looking. You can't say that this is the face of COVID-19. And so it took a while also for the population to accept that we do have that condition, because there was this stigma around, is the government looking for money from donor funding or wherever to further, deepen their pockets in corruption. And so we as a population also doubted our authorities, which was rather unfortunate. The health sector tried its best. We had quite a concerted effort from various professionals coming up to say we do have COVID-19, but there was a gag of silence, to be honest, Trevor, even within our medical circles, when we're trying to do professional development courses to find out, okay, the hospitals that have seen the first few cases, how are you managing them, what can you do? There was reluctance from those who are the front line to discuss this, because there was this fear, again, that had been put in place that this is top security, we can't really disclose. So we basically shrouded the disease in this secrecy. And so it was very hard for the population to start understanding. Remember, in the beginning, everyone was saying, I've not seen anyone with COVID-19, this is a lie. And right now, almost everyone, or rather the middle class, are now saying, okay, I actually know so-and-so, I know this workplace was affected, my neighborhood. So we are in that phase of acceptance as a population. Unfortunately, it's a little bit too late, because now we have widespread, the virus has spread to other areas because we didn't follow the containment measures as much as we would have loved to. And so now we are dealing with mitigating. So rather than prevention, we're dealing with mitigating. And in mitigating, this is where we are setting aside infrastructure, we're training our workers, we are equipping them. We are now trying to manage the disease to prevent that surge. There's a surge that the modeling from epidemiological studies is predicting. And if we don't mitigate it, for sure, we are going to go into the surge. Unfortunately, we are just at the brink of that.
So even right now as we speak, we are actually in a surge and we are seeing it happening. But how do we explain this to the people in the village to understand? Because there's stigmatization, and we've seen some unfortunate incidences where people who've moved from the cities are being almost secluded. But at the same time, we see those who are calling their people from the city to come back because they feel they're safer with them back there. How do we ensure that there's a balance of conversation so that the people actually realize it's all up to you in the end of it?
Yes, Trevor. In the beginning, and even to a larger extent right now, COVID-19 is seen to be a disease of Nairobi. And even within Nairobi, COVID-19 is seen to be a disease of those who go to the high-end hotels. So we unfortunately are in a situation where our urban areas, especially the people who are living in below the poverty line, many of them have been unable to continue with their lifestyles. And the option for them to continue sustaining themselves is going to the rural community, to the rural population. And so we are going to see quite a big urban-rural migration because of economic reasons. Now, to a great extent, our data within the rural population shows not as many cases as the urban one, but I'd peg it more to our testing capacity. So it's not to say that those in the rural areas do not have it, but it will be interesting to have, if we were in a situation, ideal situation where we are able to test everyone, I'm sure we'd get a number of cases from the rural communities. But you're right, I don't know whether we're still studying whether is it the fact that the rural population are able to also, the kind of lifestyles they live, the diets they have, their immunity to a bigger extent is much better than if you are living in an urban population, you're eating, fast foods, your immunity is low, you don't have access to 3 meals a day. So this predicts the transmission rate to a smaller extent. But the stigma, again, addressed to it is coming from the fact that our enforcement measures were very, very punitive. We told our area chiefs, we went to the community and told them, if you see someone with this, report it. So it becomes an offense to have COVID-19. And this was just driving people more into hiding and people into, avoiding, stigmatizing, calling out. I think there's some populations where, houses, were attacked by the communities because they said, you are hosting visitors from Nairobi, and so you're bringing COVID-19 to us. So there's going to be a lot of effort that needs to be put in place into breaking down that stigma, into saying, yes, you can have COVID-19, you can be asymptomatic. If you do this and that, you're able to protect yourself and those around you. So let's talk a lot more on making COVID-19 another disease that we are trying to manage to the best of our levels and not stigmatizing it the way HIV was.
So from what you've seen so far, how similar is this to HIV that you just mentioned because of the stigmatization, but also at the same time, there was more of a military approach at the beginning where there were lockdowns, cessation of movement. Should this really be left in the hands of Kenyans and say it's really all up to you, or should we be considering another lockdown? Because we are barely a month into it and the numbers are soaring.
Yeah, it's a catch-22 situation. One is if we went back to lockdown, are we going to protect the vulnerable in the society, the ones who are not able to earn a living? People have lost a lot of their livelihoods, and I'm not just talking about the people who are in low socioeconomic status. We have middle class, we have people who are relying on professions that require human interaction, that require movement. Those in the education sector have lost their jobs. So what are we telling these people? That if you go back to a lockdown, how are they supposed to continue with their, earning a living from other sources? On the other hand, is it a little bit too late? Because to be honest, Trevor, with the lockdown, people are still moving. And we've seen that through our media houses that have highlighted this. So was the lockdown effective in the first place? Were we able to really ensure that the pockets of infection, the populations that had pockets of infection were contained because people are moving? So it is a balance. And I think, in my opinion right now, it is a little bit too late to go back to another lockdown because we already have community spread. We already have people in the places where we didn't think they would have cases, having cases. And so we should, in my opinion, be focusing on mitigation. So ensuring the health sector is prepared. I don't know what that means because we need to have an overhaul of the whole health system. We have field hospitals. We have plans for field hospitals. I wish we could be concentrating on this because these are things or infrastructure that can be put in place very easily and brought down when the rough season has passed. We need to employ those health workers. I will repeat that because what we have, the frontline workers we have, are not enough to manage even the conditions that were there before COVID-19. So you can imagine right now, a health worker contracting COVID-19 requires to be isolated. The people around them, if they've interacted with the case, will also require to be isolated. And so you're withdrawing critical forces that are already limited towards managing the condition. So let's put a lot of effort in getting more health workers at the front line, from community health workers all the way to our specialists who need to manage these critical care units. And let's break down that conversation of COVID-19. I think I like what Uganda did. Uganda went into a lockdown the minute they realized there was a threat. The president took it upon himself. He even gave options of what people could do. So the communication was not military. The communication was, you and I have the responsibility to fight this together with what the government is doing, together with what the health sector is doing. So let's put back the power of decision-making, of responsibility to the consumers or to the public, but of course with proper measures of detecting or following up people who may be at risk.
So right now as we speak, yes, we are training our healthcare workers and then the front line, but where should we begin from? Where is the most critical point? Because in the villages, there are very few doctors. All you meet as clinical officers or maybe in a dispensary somewhere, and they're the ones who will come into direct contact with the first cases of COVID-19 in the villages. So where should we be trading our guns? What top 3 areas in your mind that all our resources should be channeled to right now as we speak?
Mm-hmm. So Trevor, I would say with COVID-19, it should be multi-pronged. So it's not an either-or situation. Of course, our frontline workers, our community health workers, we need to equip them with information, and I think this has been going on through various partnerships. But above all, they need to be protected. So they need to, safety first. Like when you're in an aircraft and you're going through those safety measures, they tell you, put on your mask first before putting on your neighbor's mask. So how do we ensure that these ones who are going door to door, household to household, giving information, giving hygiene measures, putting them up, how do we ensure that these people are protected? But when you look at, so those will be especially at areas where they are community health workers. I was telling someone, middle-class Kenyans, do they even know what a community health worker is? Yet this is a population that also is at risk of this. So the community health workers works very well in an environment where households have been mapped, where these people have been assigned. But if you go to our, let's say, our urban areas in your estate, Trevor, do you think you have a community health worker in your place? So you and I would most likely go to a private facility. In fact, we're seeing a number of people going to pharmacies, not even hospitals, because there's already stigma around hospitals. People fear, if I go with my cold or with whatever reason, I will get or I will contract COVID-19 because it's a high-risk areas. And so people have health behavior seeking has changed, and guys are going towards pharmacies. And yet, when we're training people, we focused on, say, community health workers, we focused on our doctors, we focused on our nurses. We did not focus on pharmacies, especially privately owned pharmacies. We have the private hospitals also. So when government sets aside some of these measures, their priority is usually in the public sector.
Yeah.
Respectively so, because this is where the bulk of the population seeks services, but also this is their responsibility. But we know that private sector, in this case, for-profits and the faith-based organizations, provide at least 49% of health services. So if we have a focus only towards the public sector, we leave a critical population, a critical health workforce that's been left to fend for themselves. So we have private facilities that do not have PPEs because they don't have the muscles of the bigger hospitals to do purchases. So it needs to be a holistic approach to ensure that any health worker, whether you're in a private pharmacy, whether you're in a community health worker going door to door, or whether you're in ICU setting, has access to information and has access to personal protective equipment so that they're able to contain this disease, mitigate. This is where we are at now.
All right. Thanks for making time for us this morning, Dr. Elizabeth Wala. She's a Program Director, Health System Strengthening at AMREF Health Africa, speaking to us about the COVID-19 viral surge. Now, it's really all up to you to ensure you stick to the Ministry of Health guidelines to protect yourself and your family as well. We're taking a quick break here on Daybreak. When we come back, we mentioned to you earlier on that it's the World Youth Skills Day. So we're going to catch up with Roy Sasaka. He's the CEO, National Youth Council. He's all the way in Tana River, so we could only get him on phone. We'll be speaking to him in just a bit.